Okay, Assalamualaikum warahmatullahi wabarakatuh. And a very good day to everyone. Well done for completing your earlier modules. So this module is basically a module on the testing modality for COVID-19. I'm going to bring you through the different type of testing available in primary care center and on whom it should be performed and what are the area of importance that we need to consider when doing as well as interpreting the test. Right, there are three types of testing available out there. Not all are available in primary care. Okay, so we have genetic testing, which uses the RT-PCR test. We have antibody, RTK antibody, which is not available in primary care, and we have antigen rapid test kit, RTK antigen, which is available in primary care. Right now, I would like to explain to everyone so that everyone understands the terminology of diagnostic testing as well as screening testing. So diagnostic testing, when you use diagnostic testing and when do you use a screening testing, all right? Diagnostic testing is basically RT-PCR, okay, because it's gold standard, it's the best to detect the virus. And when do we use this diagnostic testing? We use the diagnostic testing, RT-PCR, when the person in front of us, a patient that comes to the fever center, manifests symptoms similar to that of SARS-CoV-2 infection, COVID-19 infection, and has the epidemiological link, such as has been in direct contact with someone which is COVID-19 positive, or has been in the cluster, or has been in an outbreak in clinic, or in the hospital. Okay, so they have the symptoms and they have the epidemiological link, and they are basically high risks. So these patients are patient that must have RT-PCR test. We don't do RTK. You can do RTK antigen, but if RTK antigen is negative, we still need to proceed with RT-PCR because we know this patient is really highly at the risks of getting infection. Okay, all right. And screening testing. Now, the screening testing is totally different from diagnostic testing. Individuals that we screen are those who come to us who do not have symptoms, sign or symptoms, or do not have the epidemiological link to any exposure to COVID-19 infection individuals. Okay, so in front of you, you feel like, no, I don't think clinically, you have to clinically and assess the patient and feel that, no, this doesn't sound like COVID. And yes, on that kind of patient, you can do the screening testing using the RTK antigen alone. When the RTK antigen is negative, it is very good at saying that unlikely this patient is COVID-19. But if you suspect even a little that the patient in front of you may harbor SARS-CoV-2 virus, RTK antigen negative must be followed with RT-PCR test. Okay, so screening testing is commonly used for someone who are very low risk, so very unlikely that patient that comes to our fever clinic are those that we would do screening testing on because they are symptomatic and they are at high risk. Yeah, because they are staff and students and they live within the hospital proximity, they work, we are exposed to patients, to work-related exposure to COVID-19. So these are the people who are screening testing where you use just RTK antigen alone, basically in the community where there is no direct exposure. That is very, very safe community. So you just want to randomly test the patient to make sure that there is no COVID-19 harborer that is quietly sitting within the individuals, to pick up so that we can pick up early and then contain the infection very fast. So just like any other screening test, when we do a screening test on symptoms who are not at high risk, we will have to do it regularly at a certain interval. Okay, So let's look at what the rapid RTK antigen kit look like. So what does RTK antigen test do? Basically, the test the function is to detect whether there's a presence of nucleoprotein from the SARS-CoV-2 RNA virus. Okay, and the virus, when someone has symptoms, the area that can yield a high number of COVID-19 virus is actually at the nasopharynx. So that's why we swab the nasopharynx area or the oropharynx. Both is even better. So you can combine the yield together and increase the sensitivity. If the test is positive, meaning that the swab that you have done at the nasopharynx area has detected nucleoprotein of the SARS-CoV-2 RNA, meaning that it is positive. Now, how do we perform the RTK antigen? We at our primary care setting, we perform the swab, but we deliver the swab to the lab for them to process. Because we do not have a safe cubicle to run the test itself. Okay, and so this is our role. This is where our role is, which has been explained extensively in the earlier module on how to competently perform a nasopharyngeal swab. So basically, when you are performing the swab, you actually wanting to swab as much nucleocapsid protein. Nucleocapsid protein from the virus here, and then what you do is that you put it in the plain container as we mentioned in the earlier module, not the VTM, because swab that is accidentally put in the VTM mode, container, won't be able to be processed for the RTK antigen. Hence, a repeat swab will be needed. Okay, so we keep the swab taken in the cooler box at 2 to 8 degrees and transport it to our microbiology lab for them to run the test. The time of swab to the time when the test arrives, the lab must be within the 4 hours to prevent sample degradation. So how we perform it is quite generic, but the numbers, the detail on the rotation needed and so on pretty much depend on the manufacturer instruction. Okay, so basically what they will do is that they will take out the swab and then put, the test kit come with a buffer. So this buffer has a seal top with fluids in here. Okay, they will open the seal top and then put the swab that we have taken in here and rotate several times, left or right, according to the manufacturer instruction. And then once done, they'll take the swab out and then cover the buffer tube. Okay, some manufacturer may want to wait several minutes, seconds before we start to put the drop onto the strip. Okay. Now, what happened? So basically, when your swab actually has picked up the SARS-CoV-2 protein, the protein will bind with the SARS-CoV-2 N protein antibody and perform an antibody antigen complex, which then be filtered here, the test line. So if the patient has the antigen on the swab, when you run the test line will be visible. Okay, a positive test must first see that the control line is there. Okay, then only you move on looking at the test line. If the test line is, you can see the test line, whether faint or not so faint or very obvious, they are considered positive. All right, maybe I will change my pointer. Okay, for those, you only see a control line without any faint positive test line, and that is a negative test. Invalid test is basically when you can't see the control line. So regardless whether you see or not the test line, it is invalid. Yep, so the test will need to be repeated again. Now, when is the best time to pick up this protein from the patient? Really, when patient comes to us, we really can't control on what day of illness they come to us. But basically, this RTK antigen test is best to be done when the viral load peaks in the body. Okay. Now, if we look at the RTK antigen, this orange line, so this graph tells you when is the best time for the test to be done. So for this test to be done, it needs to be done when the viral loads is at its peak. Yeah. Okay. So as you see, the incubation period is when you have been infected, exposed to COVID, infected, and then incubating the virus without showing any symptoms yet. Okay. So 1 week before a person start to manifest with symptoms, the test start to be able to pick up. Not much, but able to, if there's a lot of yield. But the moment they are symptomatic, which is very early in the symptoms duration, first day, second or third day, that is when the test will be at its maximum, because that's where the viral load is at the peak. Okay, but there are patients who comes in later, a few days later after their illness, maybe 1 week or 5 days later, 7 days, and we know that antigen level collected beyond 5 or 7 days from the first day of onset of the illness drop below the limit of the detection of the test. So the test also has limitation. If someone comes into you symptomatic, right, but they're already like 1 week already having the symptoms quite late. So when you do RTK positive, you must bear in mind that there is a chance that this RTK antigen is going to be negative. And then that doesn't mean the patient is negative. It's just that the test is not being able to pick up at this point of time the antigen because the viral load has dropped. This is when you proceed with RT-PCR. All right. Now, what are the considerations we need to think about when we perform the test and interpret the test? We know that the sensitivity is 84 and 97. The highest sensitivity can be reached when the person who performed the test is skillful and competent in doing so, and that the test is done when the patient comes to us at the very early of their symptom onset. The moment they come to us, the moment they come later than day 3 and maybe at day 5 or day 7, after a week or more than a week, the sensitivity of the test to be able to pick up positive tests on this patient who is positive will drop. Okay. Similarly, if someone who performed the test may not be competent or miss out the nasopharynx area, then the sensitivity percentage will also drop. Okay. The specificity is almost 100%. Is not almost, it is 100%, meaning that, but remember, as we discussed earlier, specificity of this test is used when you know the person in front of you. Clinically, you assess, you ask the history, you assess this is not COVID-19. When you do the test, you can confidently say a negative test, meaning you do not have COVID-19. All right. Okay, I think the rest I've mentioned, so we move on. So precaution, I think this is the thing that commonly need to be thought of when the test result come back. Yeah. While waiting for the test result, when you have assessed the patient, like, okay, what is the chance of this test coming back positive and negative? Then what is the probability of this patient is actually positive, but the test is not really good at this point of time to actually pick up the virus? Okay, those are the things, the clinical reasoning that you should be bearing in mind when you perform the test. Okay, so the test for RTK antigen test to be highly sensitive, not 100%, but hardly, you need to basically perform the test on the nasopharynx or oropharynx area where there are plenty of virus there. And to have plenty of virus there, the patient must be able to be swabbed at the earliest point when they develop the symptoms. Okay, if the swab is done later, then the sensitivity level will drop. Okay. Now let's go to RT-PCR test. So what is RT-PCR test? It's basically a diagnostic test, and similar to RTK antigen, it actually detects the genetic, not just the protein, but the RNA material from SARS-CoV-2 RNA. Okay, and one or more genetic material can be taken either from the envelope, nucleocapsid, spike, the RNA-dependent RNA polymerase, or ORF1 genes. Okay, and similarly, you want to swab area where there's high yield of this virus, and you can use the nasopharynx, oropharynx. You can also use sputum stool or bronchial lavage materials. Okay, accuracy of the viral RNA swab depend on the size and quality of the sampling. Okay, the sensitivity is around 87 as the study which use a reference range to compare the test come back as positive RT-PCR and compare to a clinical CT scan done as a diagnosis of COVID. So when they compare that, they found that the test is able to pick up its percent of a positive CT chest for COVID-19. Another systematic review doing a comparison on hospitalized patients found that the test has a sensitivity between 73 to 95%. Okay, and the specificity is if the reference range used is a CT chest, the specificity will be will drop. But if compared to those study comparing patients, symptomatic COVID-19 patient in hospitalized hospital setting, actually the sensitivity is quite high. So, so what we do is that similarly, you will either the yield from where the RT-PCR can collect, it's best to collect is actually from the lungs, because that's where most of the virus are concentrated. So product of bronchio alveolar lavage will provide almost 93% of the virus genome. Those from the nasopharynx, which we do, will provide 60%, and oropharynx around 30%. Okay. And similarly, this is a graph to tell us about when is the best time for the PCR to be conducted, and when is it that it will never detect the infection. Okay, so before someone develop the symptoms, it's very unlikely that RT-PCR will detect anything. So even if this person has been in contact with someone who is COVID-19 positive, or has been in an outbreak, or been exposed in a cluster, if they still have no symptoms, it's very unlikely that the test will detect. Okay. However, if we see, let's just focus on the nasopharyngeal swab, because that's what we do in clinic. Just like RT-PCR, although when you are incubating, you may not detect, but the detection can start to increase from day one, week one before the onset of symptoms. Okay, so RTK antigen earlier, the peak here is very short. It dropped back quite fast here. Okay, so here the RT-PCR, the moment you develop symptoms, that's where it peaks, and then it goes up a little bit. for a week, it can still detect the virus even past 2 weeks, past 3 weeks, past 4 weeks. Past 4 weeks is very unlikely they will be detected, but it's still detectable. Okay, so hence PCR is good to be used to diagnose if patient is currently infected with SARS-CoV-2 virus, but it's not good to use to see if the virus has been eradicated, because it's very sensitive. Even after day 10 of being symptomatic, where you are no longer contagious to others, PCR can still detect the virus, and the virus is dead, but they're able to detect the RNA. Okay. Now, not going to go too high about the CT value, but you will notice that there is a CT value in the RT-PCR results. What is CT value? CT value is referred to cycle threshold. So it corresponds to the number of amplification PCR, the cycle needed to run to finally detect a genetic SARS-CoV-2 material. So when a sample is taken, the first cycle they run, they can't detect the genetic material, they will proceed the second, third, and fourth, and fifth. So theoretically, logically, that's what it does. The more cycle that you need to run to detect the virus, meaning that the viral load is very little. They have to amplify it many times to detect what is very small. But if the CT value is very, very small, 8, for example, or 9, meaning that they don't have to amplify so much, because by the 8th or 9th cycle, they can already detect the virus, meaning that there are many genetic material there for them to detect. So meaning that a CT value, a low CT value, meaning that a patient is harboring a lot of virus there and will be contagious at that time. Okay, what does it mean? Right, okay, I've explained it a bit. A CT value 25 normally detects viral load, okay? But it can be lower than that, yeah? Evidence has says that CT value of more than 30 or 35 basically is detecting a dead virus. Why it is so is that when they try to perform a culture from a patient with a CT value of 30 or more than 30 or 35, they can't grow. The virus can't grow. So meaning that even though there's a detected gene of SARS-CoV-2 within the PCR test, but the virus could not be cultured, meaning that they are already dead. Okay, so different lab may have a different CT value, a threshold to say that when the test is negative. Okay. Okay, day 10, from the onset of symptoms, the COVID-19 virus failed to be cultured. So, so that's why our country at the moment uses day 10 from the first day that your test is positive. We need to be in quarantine for 10 days before we can go out. Given that we are asymptomatic, remain asymptomatic before we can rejoin the community. All right. Now, why we offer RT-PCR following RTK antigen in our first sector? Okay, because our patients are all high risk. Like it or not, we're not screening. We're not screening well low risk patient. We are actually trying to find this SARS-2 COVID in this patient, right? So hence we do need to do RT-PCR. You may want to escape. You can escape doing RTK antigen. There's no issue. And proceed with RT-PCR. The only thing is that RT-PCR will take time to be processed within 24 hours. So if you need some information regarding whether this patient is positive or not, some documentation, you can do RTK antigen, because once it's positive, then patient we can plan things out faster. Okay, that's all. Thank you very much from me. Hopefully that information is useful for everyone with regards to the testing types in our fever clinic. Thank you very much.